the specialist in the ACHN, please make sure that you've muted your phone and your computer microphone. And also, feel free to use the chat box function to type in any questions that you may have. The questions will be answered at the end of the webinar. The role of the specialist in the ACHN. ACHN, a new direction. Medicaid has taken a new direction with the implementation of the ACHN program. We have combined several care coordination programs into one care coordination delivery system. This delivery system combined the patient first care coordination, health homes care coordination, maternity care coordination, and plan first care coordination into one single care coordination delivery system. We have learned from each of these programs, but the programs worked in silos. For instance, we have learned that once the recipient was discharged from a maternity program, their care coordination was over. When we move into as we move into ACHN care coordination, their services will most likely not be over. They can be transferred over and have a smooth transition into family planning care coordination. These programs will now work together to ensure these smooth transitions. The care coordination services will be provided by 7 different PCCM entities, and these are primary care case management entities, and that is what CMS calls them, but we have named them the Alabama Coordinated Health Networks, and we will most likely refer to them as networks throughout this presentation. This is our Medicaid website, and I'm going to take you there to show you a few things about our website and how to access the ACHN information on the website. As you can see, all across this toolbar are different titles. The one that we'll be going to is the ACHN title. And as you can see, when you pull up this, when you scroll over this title, you'll see ACHN, ACHN FAQs, ACHN Recipients, ACHN Providers, ACHN Administration, and ACHN Quality Measures. I'll quickly show you just a few of these. The ACHN FAQs have been out there since before January, and there are many areas of questions that have come in that we have addressed. I will click on all questions, and you can see that there are many pages of these questions. I won't click on any one page, but there are a lot of questions out here that should be able to help the specialist in reviewing how the ACHN operates. Now we'll go back to this, and then now we'll go into ACHN Recipients. We have made this page specifically for recipients. There is a recipient video, and it is a very nice video put together by Medicaid, and it discusses family planning, general population, and maternity, and it speaks directly to the recipients. And you can see there's also program resources down here and a way for the recipient to email us or to text us. I'll go back into it, and you can see next I'm going to go to ACHN Providers. On the provider page, there are a lot of different links that you can review. As you see, this first one is our webinar announcement for our specialist role in the ACHN, And if you click on it, it will give you details about the program today. It's got an ACHN overview. One thing I want to really show you is the ACHN contact information specifically for providers for each ACHN. I'm going to click on that. As you can see, there is a map that you see where the 7 regions are divided. And you can also see that there are phone numbers that you can reach the ACHN if needed. There's a provider phone number and there's also a recipient number. Okay. There's also a place down here where you can see notifications. You can sign up for news updates, you can email us, or you can text us. There's also down here where it says forms, ACHN, and PCP forms. And I'll click on that really quick, and you can see the referral form is right here. Okay. And you can also see under presentations, we have provided 7, I think this is our 8th webinar. We've provided 7 webinars previously. They're all listed out here on the website for your viewing. And you can also pull up the slide presentation too if you don't have time to look at the webinar, but the webinars are very good and go right along with the slide presentations. Okay. Okay, I'm going to talk a little bit about our BMI reporting from a specialist perspective in Alabama Medicaid, and it's just one small slide with 2 items on it. Specialists will not be required to submit a BMI on the claim. We are not going to require the specialist to do that. And then pregnancy diagnoses are excluded from the BMI requirement. Now we'll go into referrals. The ACHN is a new program that operates in a different way. Recipients are not assigned to a PCP, and so there are no longer any panels associated with the ACHN program. I want to also clarify that the EPSCT referral process will not change. The referral process. PCP referrals to most specialists will be required for the specialist to receive payment, such as DME, orthopedics, cardiology, hematology, and oncology providers in the past have been excluded from the referral requirement. In the ACHN, they will need to work with a PCP to make sure that these referrals are obtained. Referrals to nurse practitioners or PAs collaborating with specialty groups will also need a referral. In the instance when a PCP cannot be identified or is not attributed, the ACHN can provide a billing referral for the specialist. Determining who needs to write the referral. In the past, prior to 10-1, a provider looked up the patient's assignment on the web portal. Today, there is not an assignment. What you will see on the web portal is the recipient, who the recipient has been attributed to. An attribution does not equal assignment, and I'll go into attribution in the next slide. Attribution is the process that will be used to associate a Medicaid recipient to a Medicaid PCP group to the source of the majority of their care. An attribution does not mean they are assigned to a PCP. It does mean that when you look out on the Medicaid web portal, that you will see who they've been attributed to and who has provided the majority of their care. It could be a PCP, it could be a health department, it could be a specialist such as an oncologist or a hematologist. And again, attribution does not equal assignment. Key steps in the attribution process. Medicaid recipients who meet criteria for the ACHN program for 3 out of the previous 24 months will be attributed. This does not have to be a continuous period. The previous 2-year history of face-to-face provider visits, and I'm going to go into just a few things that are included in this. Both preventive visits and regular office visits are scored. Preventive visits receive a higher point value. Recent visits are scored higher than older visits, and PCP visits receive a higher point value than specialist visits. The previous 12-month history of filled prescriptions for chronic care conditions are also scored. This could, if the recipient was on an asthmatic medication and normally got those filled, it counts those towards that attribution. Again, attribution does not equal assignment. The specialist referral come from any PCP, which may not equal the attributed provider. That means when you look up on the web portal, you may not see that PCP. So the first thing that the specialist should do in determining is to determine the PCP as you would with most other insurers. First, ask the patient who their PCP is. Determine who made the contact with your office to set up the appointment. If this does not yield a PCP, then after all efforts have been exhausted, then contact the ACHN for a billing referral. The ACHN will work with the patient to establish the PCP. Referrals dated prior to 10/1/2019 continue to be valid until the expiration date of the referral, unless the PCP who made the referral is a specialist and did not enroll with the ACHN program. In those instances, you can still call us so that we can help you work through that, or call your ACHN program. The recipient's PCP should be contacted for a referral if one is needed for dates of service 10/1 and after 10/1. Specialists should not request referrals from health departments. An exception to this is Jefferson and Mobile counties, other specialists, or children's rehab services. For more details on services and provider types, see Chapter 40 of the Provider Billing Manual. For teaching facilities only, specialists that are linked to a teaching facility will not need a referral and may also make referrals to other specialists. Medicaid considers all providers linked to teaching facilities as part of a PCP group. Medicaid will monitor these changes in utilization and will determine the next steps. Referrals continued. Some services do not require a referral, such as administration of allergy injections, ambulance services, certified emergencies, radiology services, laboratory services. Some provider types do not require a referral. County health departments, CRS, hospitals, independent radiologists, pathologists, dermatologists, community mental health centers. A complete list of these services and provider types that do not require referral are in Chapter 40 of the Provider Billing Manual. To recap, referrals dated prior to 10/1 continue to be valid until the expiration date of the referral. The recipient's PCP should be contacted for a referral if one is needed for dates of service 10/1/2019 or after. If the recipient does not have a PCP, then the specialist may contact the ACHN for a billing referral until a PCP can be established for the recipient. Specialists should not request PCP referrals from health departments other than Jefferson and Mobile counties, other specialists, or CRS. A referral is no longer needed for PCP to PCP visits. Referral Form 362 has been updated and is on our website. A referral is still required for most specialties and EPSDT screenings that are referred outside of the PCP practice. Also, keep in mind that EPSDT services do have to have an EPSDT referral. So it's whoever is providing a service, an EPSDT service, must have that referral. And again, see Chapter 40 of the Provider Billing Manual for a complete list of services and provider types that require referrals. For additional ACHN information and frequently asked questions, you can go to our website and also submit any questions that you may have to the ACHN email address. It's achn@medicaid.alabama.gov.
This is Dr. Moon. I wanted to give a couple of spots a little bit more emphasis and to reiterate them. First of all, one of the biggest points to reiterate is that attribution is not the same thing as assignment. For 20 years or so, there's been a patient first program has existed, and individuals were assigned to patient panels for primary care physicians. The panel system has gone away, so there is no assignment now. So I want to stress that. So when you go to the provider web portal and you look up who they're attributed to, attribution is not the same thing as assignment. Attribution simply indicates where they have received most of their care. Most of their care may have frankly been provided by another specialist for some reason who should not be the source of a referral. So that is important. So how do you determine who to get the referral from? Well, you can actually receive a referral from any PCP. Obviously, you would like to get it from the PCP where they have been seen primarily for their care. And like you would do with other insurers, you can ask the patient, who do you primarily see for your primary care? The patient may not know. And in that situation, obviously, hopefully, the primary care practice has made a referral in the usual way, irrespective of Medicaid's referral process. They've made some contact with your office obviously you can usually determine from there where the patient had been seen before. If neither of those two are helpful for whatever reason, then you can contact the ACHN to obtain a billing referral. The purpose of the contacting the ACHN obviously is for that billing referral, which is a temporary device to help make it easier for you in terms of seeing the patient. But the other purpose of contacting the ACHN is so that the ACHN can establish the patient with a primary care practice. And they will work to do that after your contact. Now, if you have trouble contacting the ACHN, or for whatever reason you have an issue there, then you will need to contact Travis Hauser at Medicaid, and we have provided his contact information previously, and we can provide it again in follow-up to this webinar, and we will do that. So let me stress again, attribution, what you see on the web portal today, is not the same as assignment that you have seen in the past. So again, there may be an attribution to a specialist, there may be an attribution to even a health department, that sort of thing. That is not the same as assignment. And many health departments do not provide referrals. There actually are only two exceptions, and one is Mobile, and the other is Jefferson County. And even there, it is only for the recipients that they've been seeing. So if you're seeing a recipient a long way away from either of those two places, don't contact Jefferson County Health Department or Mobile Health Department. You only contact them if the patient has been seeing one of them as their source of primary care. Other health departments that have not signed a PCP type agreement, which is basically all of the others, are not to be considered sources of referrals. It's a critical point. You need to figure out who their PCP is by, again, discussing with the patient, looking at who contacted your office to make the original appointment, or if necessary, and only if necessary, after the other two have failed, would you contact the ACHN. So I did want to reemphasize those points, and we'll turn now to the questions. So I'm going to hand it off to Drew Nelson. One of the first questions we have is relative to hematology, oncology. Historically, and Jerry pointed this out a few minutes ago, hematology, oncology patients were excluded from the patient first population, which meant they did not have to have a referral. It is important in the new program that the hematologist oncologist office does have a referral. They are included in the program, and it is important for the primary care physician to be aware that the hematologist oncologist is seeing the patient, and the referral should be gotten from there. Now, the primary care physician can provide an extended referral time period so that it's not at every single visit you have to get a referral. So please, to the hematologist and oncologist, if you need an extended referral time period, please communicate that with the primary care office so they can simplify the administration of that part of it for you.
Okay. The first question we have, if a patient has Medicare or Medicare replacement plan as a primary and Medicaid as their secondary, is a Medicaid referral ever required? That is a separate, that plan has not changed, that process has not changed. Anyone who has Medicare and who we consider a dual, has Medicaid and Medicare insurance, is excluded from this program. So these, the referrals from primary, that is not been affected by ACHN. If a patient who has only seen their OBGYN in a 2-year period then becomes attributed to that OB for referrals to specialists, that is correct. If all they've seen is OBGYN, then they would be attributed to that OB. We have also made the decision where OBs are now considered a primary care provider so that the OB can provide referrals out to specialists if they are providing primary care. There was a question about previous webinars. All of the previous webinars are on the website as well. This was not initially scheduled, but after when we went live last week, we did get a lot of questions about specialists, so we scheduled a specific presentation for specialists to go over all of this information a second time.
This is Dr. Moon again. While mentioning attribution in particular on the webinars, Today, we just touched on attribution. If you want to know more about attribution, one of the webinars is entirely dedicated toward attribution. So if you do want to understand it more, certainly you can go to that webinar. It's live on our website, watch that, and hear in detail the various parts of attribution.
All right. As an oncology practice, we have patients that were in a treatment regimen and did not need a referral prior to 10-1. A new referral is necessary. That is correct. You need to contact the primary care provider, and again, that might be a primary care provider who they've been attributed to, but if they've been seeing you most recently, you were probably the one attributed to it. So you just need to ask the patient, who is your primary care provider, just like you would for any other payer. And if for some reason that patient says we do not have one, we don't know, we've never seen anyone else, then you can reach out to the ACHN to get that. With that as a follow-up question, someone asked, how do we get the referrals? I have pulled up the website. This is under the ACHN provider page. This is the map. And if you will notice, under the fourth column is provider number. There is each ACHN has a specific number for you as a provider. That is the number that you can call. They are manned Monday through Friday, 8 a.m. to 5 p.m. to get referrals. Was a letter mailed out to all Medicaid recipients about the change? Yes. All Medicaid recipients received a letter. We have also done a lot of outreach to our recipients, as well as a copy of that letter is posted on the Medicaid website so that if you have any questions or if any of your patients come in, they don't know anything about it, you can pull up a copy of the letter on the website and have that as well. There's a lot of different resources on the Medicaid website that we've put out there so that you can add into your office if you want to. Jerry, there's a question here about, would you go over the teaching specialist referral again? Referrals can be made between specialists without involving PCP for teaching facilities.
There is a slide, and I'll go back to it. This slide is for teaching facilities only. Specialists that are linked to a teaching facility will not require referrals and may also make referrals to other specialists. Medicaid considers all providers linked to teaching facilities as part of a PCP group, and Medicaid will monitor for any changes in utilization patterns in the future.
All right. Follow up with that. Is that the only teaching facility as a group that does not require a referral, or is an outside clinic like Franklin still need to give a referral to the teaching facility? Also, if no referral is required, how do we go about EPSET so that the child does not exceed their visit limit?
An EPSET screening is different because EPSET screening services have to have an EPSET screen to be referred. So you must continue the EPSET screening process.
Well, what about if they see an outside provider like Franklin Primary, but they're being sent to a teaching facility for specialty care? How does that work?
The teaching facility does not have to have a referral, but a provider that is referring to a specialist there may need to send one because the specialist may like a referral, but the specialist does not have to have a referral to see a recipient if they're linked to a teaching facility.
We've also received a question about a particular PCP office in one particular city that refuses to give any referral for more than 2 visits at a time. I think you have a couple of options there. Obviously, first and foremost, try to work with that PCP to explain why you need more than 2 visits at a time, to have some medical reason that would be appropriate. You may do that, and for whatever reason the PCP office still chooses not to do that, then certainly I would encourage you to work with your ACHN around this issue to see if they can help you in regards to this, again, obviously with medically justifiable reasons. So those would be the 2 options in that scenario.
How does this impact anesthesiologists both in the OR setting and the pain clinic setting?
If an anesthesiologist has to have referral today, they would have to in the future. Go to Chapter 40. I know there is some information about anesthesiology. I guess we can go.
I would just search. Okay. Let's go back to the oncology and hematology. Yes, you did not need a referral unless it was in chemotherapy treatment. When you are seeking a referral from a primary care provider, I would highly encourage you, when you communicate with that PCP, to let them know that they are in active chemo treatment and that they can offer a referral, a cascading referral to you, and it will last for up to a year, so that you can ask for a year-long referral and make it a cascading, so that way you will have all of it covered, so you only need one referral for that entire treatment period. So as an OBGYN provider, I now need to sign a PCP agreement along with the ACHN agreement, is the question. That is not true. You do not have to. If you are a OB and you're providing primary care, you can, if you choose to, and you want to be eligible for the primary care bonuses, you can sign a participation agreement, but you do not have to. To also remember, if you sign that agreement, you do have to meet the participation requirements. If you just want to do the primary care and without being eligible for the bonuses or anything like that, you do not have to sign a PCP agreement. If you still want to provide maternity services, you will have to sign a DHCP agreement, though. If you do want to provide maternity services, you do have to sign a DHCP agreement.
Yes, just to emphasize that, we were responding to a request from some OBGYNs in the state regarding the ability to do referrals. They do not have to sign up as the PCP agreement. However, we have made it possible for the OBs to generate referrals, again, to decrease administrative simplicity, or to make things more administratively simple, such that the OB did not have to reach back out to the PCP to make a subsequent referral. So they can do that even if they choose not to sign a PCP agreement. Obviously, if they would like to sign a PCP agreement, they're welcome to do that, but they do have to meet the requirements as Drew just stated a minute ago. I do want to go back to one issue regarding anesthesiologists, and we're going to have Jerry answer that question for us.
I wanted to clarify on the anesthesiologist question that anesthesiologists do not have to have a referral. They do not have to have a referral for their inpatient services or the services they provide in the OR.
All right. There's a couple questions about the eligibility screen. There are some patients, if they have not had 3 months eligibility, if they have not seen anyone in the last 2 years, there will be no attribution. I mean, because the requirement says you must have eligibility and have claims within 3 of the last 24 months. If there is no one showing at that point, you still can ask that patient who their primary care provider is. That's your first step. If they say if they don't have one or have never been to one or can't remember who they saw last, that's when you would call the ACHN. Just because there's not one attributed does not mean that the referral is not needed. You would just have to go that extra step of actually asking the patient to see who their primary care provider is. And it's also why we gave the ability for the ACHN to issue a referral only in these situations when there is no PCP available or they have none, because that's one of the roles the ACHN is supposed to do, is to work with them to find a PCP. There was a question about printing the slides. Yes. Not only will the slides be posted to the website later today, but also all of the videos, the webinars have been posted. And they're also posted, they're a YouTube link, so any of your staff can view these at their leisure anytime that they want to. If a patient comes to a teaching facility for specialty care, but they need to refer out to a non-teaching facility specialist, how will this work?
The specialist may provide a referral out to the non-specialist, because for teaching facilities only, the specialists that are linked to the teaching facility will not require the referrals And they may also make referrals to other specialists, and that's inside the teaching facility and outside.
There is a question about getting an ACHN referral for 1 year if the PCP cannot be found. No, that will not be allowed. We have allowed the ACHNs to do a 1 month only in the month of October referral for those who are in active chemo treatment, because care coordinators will not begin until November 1. After that, those are limited. The ACHN's referral is a different type of referral than normal PCPs give. It is a billing only, and it is a way to try and reduce some of the administrative burden if it's an emergency. After that point, the ACHN only is going to give basically a one-time referral. They cannot do cascading. They cannot have a referral for a year. The reason is the ACHN needs to work with that recipient to find a primary care provider. So they are working only in the case of emergency where there is no PCP or the patient has never seen a PCP. Please, we encourage you to ask the patient who their primary care provider is before you contact the ACHN. And one of the questions, in ophthalmology, we require referral on all of our patients since most of the time, most all turn to medical in the exam, diabetic, cataracts, dry eyes. The patients are not having screenings, so the primary doctors do not want to give the referral. Will the screening still be required for referral for an eye exam? Whether they have problems or not, they put eye exam on the referral. If there is an eye problem identified during EPSDT screening, a referral is still required. Can you provide the link to the letter that was sent to the patient? Can't find it on the website. Yeah, just 1 second. We're moving to the Medicaid website. If you go to ACHN, you go down here to ACHN Recipients, Program Resources, here's contacts, and here is the notice that we sent to the Plan First and the Patient First Maternity Program recipients. This is a draft letter. Obviously, you noticed everything was out. And this blank here is blank because that we filled that in per recipient based off their address, what ACHN they have. So that's when you would need to refer back to the map. What about referrals for anesthesia, pain management office visits, and pain management injections? Yes, referrals will still be needed for that.
They will not be needed for anesthesiologists for those clinics.
Yeah, this is Dr. Moon again. Let me stress that because I know you just heard a brief whisper of a different answer, but the clear answer is the anesthesiologists do not require referrals. I want to establish that very clearly, inpatient or outpatient. We've expressed that in our FAQs in one of the pages and also in the provider manual that's been described. So anesthesiologists, inpatient or outpatient, do not require referrals.
Again, some questions about chemo. We removed the exclusion because just because a patient is under active therapy or active treatment, that patient still needs to have a medical home. The whole point of the design of the ACHN was to expand the role of care coordination and to expand the importance of a medical home. Just because you are providing active treatment to a patient now because of chemo does not mean that they don't have a medical need and need for a primary care provider to manage all the additional concerns that they might have, especially after they end referral. Will the teaching specialist be required to send out the paper referral to the outside specialist, or will this be the responsibility of the PCP even though the teaching facility specialist referred out? Will the teaching specialist be required to send out the paper referral to outside specialists, non-teaching facility specialists, or will this be the responsibility of the PCP even though the teaching facility sent it out?
Okay, so Dr. Moon, we will take that down and give you a written specific answer and follow up to the webinar today.
OB doctor has to have a referral from ACHN, but not the PCP. Yes, OBs for maternity care. That is part of the project. Every maternity patient must have care coordination from the ACHN. That is the reason why we designed the program. For questions about OB and needing a referral for services, please refer back to the participation webinar as well as the DHCP nuts and bolts presentation. The agency is not removing the 14 office visits. Children in foster care may be in the custody of a county in one region but live in a foster home in another region. If there is need for care coordination or other issue comes up, which region should be contacted? It should be the region that they currently reside in. We have provided all the ACHNs all of the information that we have on foster children, and there is the ability for them to look up if it's an eligibility. If they identify that it is a foster one, they know that they may or may not be in that region, but they can still provide care coordination for them.
We recognize, Dr. Moon, again, we recognize this is a challenge because of the foster population moving around frequently. Over a year ago, we met with DHR and discussed the inclusion of foster children into the ACHN program, and they advocated to include foster children in the ACHN program. Obviously, the networks need to be nimble in trying to respond to where the foster child is residing, but their responsibilities rest around where the foster child resides at that time at the need of care coordination. It just makes sense. Obviously, the care coordination staff exists within a region, and it's easier for them to work with the child that actually lives in the region. If the child transfers, moves to another spot, then the ACHNs should speak, both the original ACHN and the new spot where they're moving to help provide some smoothness in their care coordination activities.
I tried to file an H-1000 online claim, was suspended for no pricing segment is on file. Who should they contact about that?
They can contact DXC, the Provider Assistance Center, or the provider reps. And I'll give you the telephone number for that.
The contact number to the Provider Assistance Center is 1-800-688-7989.
Where in the provider manual can I find information about the teaching facility? I truly do not understand this process. Under ACHN, under provider, here is the chapter, provider manual chapter 40. We corrected a direct link here for that. Jerry, where is the teaching facility information? Is it throughout?
Do a search, because I think I have it in the...
PCP determination to be identified as PCP for billing and referral process purposes. The provider must be one of the following. Number one, teaching facility. If a patient has an ongoing medical problem, such as a retinal problem due to diabetes, is there any way to increase their medical visits, as they most likely being seeing each other doctor multiple times? That would be if the child, EPSCP, could expand, correct?
Someone under the age of 21, they are
Okay, for an adult that's over the age 21 and older, the 14 office visit limit, that is the benefit limit for the calendar year. If someone is under the age of 21, you can code your claim with the EP modifier, and we have details of those instructions on our website.
All right. We are on the Gulf Coast, and patients from other regions vacation here. Can we see patients from other regions as a PCP for sick visits, or should they be referred to urgent care or ER? Yes. If you are a PCP and you want to see these patients that are down on vacation, yes, you are more than welcome to see them. That's one of the benefits of the program where we remove the referral from primary to primary and giving the recipients the ability to see whichever primary care provider that they want to. So if you, as a PCP, want to be able to see them, then yes, we highly encourage you to do that, and it actually keeps them out of the ER. We would encourage you to ask who their PCP is, their normal PCP is, and just to send the information back to them. But yes, it is possible for you to see them. What determines teaching facility status? How do you determine teaching facility status?
That information for how to know whether or not you're a teaching physician is in our state plan in the section 4.19B.
And this is Dr. Moon. I would encourage you, if you're interested in that, that you contact either UAB or USA regarding that, and to contact their provider representatives to have a discussion about that.
There's a question about, can you print the slides? Yes, all the slides will be posted as a PDF, and so that therefore you can you can print these at any point. You're also more than welcome to download and save them too. I'm trying to find, there was a question about the referral. I'm trying to find it in chapter 40. There's BMI. Here are the referral requirements. Everything in here is about the referral problem. Referral process for PCP to specialist. Services not requiring a PCP referral. Services requiring a referral. And here's that question about anesthesiology. Anesthesias exception, anesthesiology consults performed in the inpatient hospital setting do not require a PCP referral. Consults performed in a setting other than inpatient hospital require a PCP referral.
I see the conflict between those requiring PCP referral and those not in relationship to anesthesia. We will clarify that. As I stated earlier, anesthesia services do not require referral, and we will remove that from this section where it says there is a requirement. So again, anesthesia services, inpatient or outpatient, do not require referral, and we will be correcting this part of the provider manual.
Will specialists who live in a continuous state require referral? Contiguous state, next door.
Yes, that is all specialists that are identified in our manual will still require a referral.
Does surgery require EPSCT in a teaching facility?
EPSCT referrals for EPSCT referred services still require an EPSCT referral.
Any additional questions, please type it in the box now.
This is Dr. Moon again. While we're waiting on a few minutes for additional questions, I do want to stress a few things to you again. Obviously, I've said this before. I want to say it again because I recognize it is new. The program has been operated in a particular way for probably approximately 20 years, and relationship to the Patient First program. No single program is perfect. We recognize that. The Patient First program was not perfect. This program is not perfect, but it does decrease some administrative burdens. When you look at it in total, some people would say, well, my administrative burden is more. Others would say my administrative burden is less. In aggregate, the administrative burden is less. However, we do recognize that for when you change a program, that it takes a while to adapt. And we understand that. We're all having to adapt. Obviously, you've seen us deal with questions here today relative to this program, and we're trying to make sure we give you the exact right answer. And we did identify this problem in our manual relative to anesthesia. We're going to clarify that. We recognize that, but we also recognize you all are dealing with adapting to a new system also. And it's going to take some time, but we will work through this and we will get the transition made. So I wanted to stress those. And then we have a few more questions, I guess, that have come in.
There was a question about those with breast and cervical cancers, Medicaid coverage. Are they in the ACHN and will this apply to them or not?
They are in the ACHN. Those recipients are in the ACHN, and referrals will still be required to specialists.
Teresa, we have seen your question about the teaching facility and the manual. If you will please email that question specifically to the ACHN inbox, that is back at the presentation. Let me go close this. ACHN at medicaid.alabama.gov, and so we can get you a specific answer to that and answer all the questions about that, and they can we can have our provider rep group reach out to you as well.
So we do have a question about, are we going to be paid while we, quote, adapt? Thank you for that question. Yes is the short answer. You are going to be paid, as we have been careful to do, and we will continue to do that. There is an adaptation period, but you will be paid. Let me discuss that specifically relative to primary care physicians. There has been a transition time period moving from their historical case management fees into the bonus system. We are providing some transitional payments associated with that, but they are associated with specific objectives of the program and they are related to attribution. But we will make every effort to pay for claims that are qualified claims and for their applicable dates of service. There is a question again about regarding the amount of visits to children under 21. I'm going to ask our physician program folks to come forward again and try to address that question.
Children under the age of 21 can get more than the 14 office visits. It does have to be a result of an EPSCT screening. Those details we can actually have, I guess, send that out through ACHN, or it's on our website that talks about when to code on your claim for a periodic screening, an interperiodic screening, and how to what modifiers to put on the claims to allow more than the 14 for someone under the age of 21.
All right. As the time has ended, we are going to end this webinar. We thank you for all your participation, and hopefully we're able to answer a lot of questions. Again, after you view these webinars, after you present these slides to your staff, if you have any additional questions, you can always submit them to the ACHN inbox, and they are being responded pretty quickly.
Just to handle one of the questions that's come in regarding concerns that OBGYNs in certain areas have regarding urban versus rural reimbursement, I encourage you to reach out to your ACHN for an explanation regarding that, and that issue is true for other questions like that. You can certainly first reach out to them for an explanation regarding that type of question.
Thank you very much, and have a good evening.